நிமிஷம் வந்துருச்சுன்னா வரல. இது வந்துருச்சுன்னா ப்ளஸ் பண்ணிக்கலாம். வந்துருச்சா? எனக்கு வந்துருச்சு பாருங்க. வந்துருச்சா? அது க்ளோஸ் பண்ணிட்டு சரி, நம்ம யூடியூப்ல இருங்க. ஒரு நிமிஷம்
afternoon, madam.
Stop listening. Yeah. பேசுறது மட்டும் தானே மீட் ஆன் பண்ணி பேசலாமே நம்ம தானே ப்ரெசென்ட் பண்ணுறோம் ஸ்லைடு போடுறோம் போஸ்ட் எடுத்து ஏன்னா அவங்க ரெப்பீட் காமிச்சு பெஸ்ட் நீங்கள் அவர் ஸ்லைடை போட்டு வச்சுக்கோங்க
Am I audible? Am I audible? Thank you.
Yes, sir.
Thank you, sir.
Good afternoon, everyone. KMCH College of Physiotherapy welcomes you all for this final day of faculty development program. It's my honor and privilege to introduce Dr. Sivaguru Muthuswamy. Dr. Sivaguru Muthuswamy, who is distinguished expert in the field of pulmonary rehabilitation, both in clinical and academic realms. With over 21 years of experience, Dr. Sivaguru sir contributed to pulmonary rehabilitation exemplarily in India and Malaysia. Currently, he is working as pulmonary rehabilitation specialist physiotherapist at the Center for Advanced Lung Diseases and Lung Transplantation in KMCH Hospital, Coimbatore, India. He has numerous publications and awards in his favor. Today, I invite Dr. Sivaguru sir to deliver a talk on assessment of VO2 max. Over to you, sir.
Thank you for the introduction. Okay. Shall I have my slides, please? Okay, so this slide shows the department at KMCH, COVID Medical Center Hospitals. Is a pulmonary rehabilitation department where I am working here under the Department of Pulmonology as well as the Center for Advanced Lung Diseases and Transplant. So next slide, please. So today's topic, what I'm going to cover is assessment of VO2 max. VO2 max is an important parameter where in the cardiopulmonary rehabilitation we use this term very much, as well as in the sports field also. So I'm going to give an overview about like another 20-30 minutes of session. I'm going to give an overview of this assessment of this VO2 max. Okay, right. So what we are going to learn today is we are going to define VO2 max. What is VO2 max, and we are going to be going to the definition of that, as well as we'll be describing about physiological basis of VO2 max and its influence on the VO2 max, and differentiation between direct and indirect methods of assessing the VO2 max. Actually, there are some indirect method is the gold standard method, and indirect methods are the field tests and other tests that how we can calculate and derive the VO2 max that we are going to see. And the next one is the interpretation of VO2 max results in the context of age, sex, fitness level, and performance goals, and based on the diseases also we are going to look into the interpretation of results like over. It's not very much into the deeper into the context actually, and why it is useful, why it is needed in our field that I'm going to discuss a little bit about the need of VO2 max in the field of physiotherapy. So these are my today's topic that I to cover. So what is VO2 max? So simple words, VO2 max stands for maximum oxygen uptake by your body. So how much oxygen that your body can uptake and utilize. Hello, is it audible? Hello.
Yes, sir, you're audible.
Oh, thank you, madam. Yeah. So in the simple words, it is how much oxygen our body is using. Maximum, if our body is using maximum of oxygen, it means to say that it's good actually. So we are more fit. We are able to use more oxygen. That is what the meaning of VO2 max. So VO2 max can be defined as the maximum rate at which the body can take in the oxygen and transport and use that during intense exercises. So please go through that again, once again. I'm going to go through that once again. The body can take in the oxygen, how much you are breathing in, transporting, and delivering where it is needed. So all together, we are measuring through the VO2 max. So it is very important. This term is very clear actually. So it is a key indicator of cardiovascular fitness and aerobic endurance actually. So how much you are taking, transporting, and using. So all the three components are must in this, right? So indirectly we are assessing all the three components when we are assessing a VO2 max. Okay. Why is it important, VO2 max? Is this like any other parameters which cannot show any of the things, and why this VO2 max is given so much of importance in sports as well as in cardiorespiratory pulmonary rehabilitation? Why is given so much of importance? Because it is not that hero actually. I mean to say it's a superhero. If you are fit, for example, if you are physically active, you can call it as a hero because nowadays the diseases are like that. If you are moving around, we become a hero for some extent, especially into the context of cardiovascular respiratory diseases. If the patient is moving around, he's already is good. He's a hero for us. But if you wanted to make him more fit, he becomes a superhero or an action hero. That's what. So VO2 is like an action hero. Mean to say, it shows how fit you are and aerobically healthy a person you are. That's what the VO2 max says. So it directly indicates fitness. Fitness has many components. One of the component and the important component is endurance. We have strength, agility, also is there, power and everything. But this endurance is a primary component in the fitness. So without endurance, we cannot say that the other components are like, okay, it looks like a secondary actually. So higher the VO2 max, better your endurance and your cardiovascular performance. That is what it is more needed actually. So higher your VO2 max, better the endurance, and you are having a better cardiovascular performance. So athletes often aim to improve VO2 max, but it is useful for everyone, even for daily activities and overall health. So that's why VO2 max is very important. Nowadays, in ACSM as well as in the American College of Physicians also, they are training the general physicians how to prescribe and how to assess the exercises, actually exercise performance. So you see that the general physicians are learning about the fitness. General physicians are learning about the physiotherapy because the the scenario is moving towards more into the exercise components. Exercise is becoming a part of medicine. Exercise is becoming a important, vital part of a medicine, actually. So, someone wanted to do a proper exercises. If you wanted to know their basic capacity of exercise, the best gold standard measurement is VO2 max. So, based on that, we can prescribe the exercises. So, that's why the VO2 plays a very important and vital, actually. Next slide, please. So the next one, what is the physiological basis of VO2 max? So for this, for the easy understanding purpose, I put a diagram here. So as like the ChatGPT helped me in drawing this diagram, actually, like others also, I use this to draw my ideas into the diagram, actually. So where oxygen delivery like a water supply system, you assume that oxygen delivery is like a water supply system. Assume that your lungs are like a water source, where you are. It is a source of oxygen, right? Anyway, ultimately, so your lungs needs to have more oxygen, receive more oxygen from the atmosphere. It becomes a source. Then this oxygen is pumped via the heart to the needy area, where we can call it as the muscles or the working area. So it becomes like a ground, right? So if you assume that the water supply system, the lung has a reservoir. Lung becomes a reservoir like a water source. The heart becomes like a pump, where from the reservoir, the heart pumps the blood into the muscles, where the muscles are we can take it as a field where it is required the water, like a cultivating field. That's all. So when you have a good reservoir system, when you have a good pump, when you have a potential cultivating land, that is the muscles, definitely you will have more amount of crops that you can eat. That's what the meaning, actually. So you have a reservoir, good source, good pump, good cultivating land like muscles, where you can use it efficiently. Definitely the yield is good. Definitely the power is good, your endurance is good, or your capacity is good. That's what it's explained over here. I think some clarity you may be getting it on VO2 max. See, VO2 max measures how much oxygen can reach the area where it is required per minute. VO2 max is measured in per minute. Per minute, actually. A better system, more water to the field, a healthier, more productive field. That's what I mean to say. A better overall, better system, including lungs, heart, and the field. It becomes a better system, and your yield will be good. Your endurance will be very good. That's what. So we inhale oxygen, the right side of the diagram. We inhale oxygen, oxygen-rich blood from the lungs to the body. It's circulated by the use of pump. The heart, it goes to the muscles. The ATP, ADP, all the reactions, Krebs cycle, everything happens. Krebs cycle runs with the O2. Then the CO2 enriched blood comes back to the heart, to the lung, and exhaled through as like a CO2. That's what. So this cycle is happening every time, every day, every minute. Everything is happening for everyone. But how efficiently it happens, that we need to assess, means we need to use and we need to assess through the VO2 max. This is what the basis of assessing the VO2 max. Hope you all understood. Yeah. Next slide, please. Next slide, please. Yeah. So here we have important components are working here. Respiratory system, cardiovascular system, muscular system, and oxygen extraction. That is arteriovenous difference. That's what it is the basis of VO2 max. So the lungs inhales oxygen, exhales CO2, and it transfers and pumps and it goes into the muscles, actually. Right? Is it clear? Okay. Now just a few seconds for the previous slide, please. Previous slide, please. Yeah, thank you. If you see, if you are having a poor reservoir system, the water source is leaky, your water source is not good enough, or water source is having some problem, it is not able to store, that is lungs. Lungs are not able to hold, are not able to utilize more, means create more oxygen, problem will be there. The plumbing system, in between one system, the very important system is the plumbing system, where just assume that the pulmonary arterial system, where it carries the oxygen from the lungs to the heart, just for example, I'm saying, if there is a plumbing system in this pulmonary arterial system, also there will be a problem in VO2 max. If you're having a problem in the pump, the heart, there also problem will be there in the VO2 max. And another peripheral plumbing system where supposed to take the blood to the field, mean to say the field where the muscles are there, the peripheral circulatory system is having a problem. There also VO2 max will be decreased. And if your field, whatever the oxygen is there, whatever the pumping is good, whatever the pumping system is good, everything is fine, but your field is not cultivatable, right? Then definitely your VO2 max will be poor. So all these systems are contributing in the VO2 max component actually, right? Okay, next slide please. Next please. Yeah, thank you. Next one. Next slide. Next one. So the next slide is explained about what's the relationship between the VO2 max and the heart rate. So because heart rate is very important, why? Means like unless like the gold standard method of assessing VO2 max, we use a metabolic cart where it uses the oxygen and carbon dioxide, how much we are inhaling, exhaling, everything will be captured and it will be calculated automatically and you will be getting the VO2 max value. That's fine. But the other indirect methods where all the VO2 max is calculated, especially using the heart rate. So the heart rate component is very important for that. If you are working, if you are doing exercises, hit whatever it is, high intensity exercises, whatever it is, whatever the exercises you are intensity you are increasing, parallelly we have to increase our heart rate also. Means heart rate is supposed to increase. So if it is not increasing horizontally, parallelly, it goes flat, there is a problem. So based on that only all the indirect measurements are calculating the VO2 max. That's why I have given some importance to the heart rate and I have created this slide. See, VO2 is directly we can calculate by means of heart rate multiplied with stroke volume multiplied with arteriovenous oxygen difference. Is it clear? The first one, VO2 is you can calculate heart rate into stroke volume into, I mean to say multiplied with arteriovenous oxygen difference. How much oxygen is going in and how much oxygen is after utilizing, after going into the Krebs cycle and how much oxygen is coming out is the difference. For example, how much oxygen we are inhaling is 21%. And how much oxygen is supposed to be, of course, exhaling air also will contain the oxygen. It will maybe around 16% or 17%, whatever it is, how much it is used and it's coming out. Okay, so that is the formula for calculating the VO2 max using the heart rate. If you are having a heart rate and stroke volume, if you are able to calculate. Fine. So based on this formula only, we will be using the direct calculation. The CaO2 and CvO2, means arteriovenous differences, will be calculated using the metabolic cart and it will be calculated using the CPET machine by means of a direct measurement of VO2 max. Okay, next slide please. Next slide please. Yeah, another important one. When we talk about VO2 max so much, we need to be saying about what are the differences or what are the factors that can affect VO2 max, which is very important to know because without that, we cannot expect everyone will have a good VO2. Some basic differences will be there, individual difference principle will be there. So that like that, we have the difference for some factors maybe influencing the VO2 max person to person. One is age, another one is gender, like the age, another two parameters also there. Age, of course, VO2 max peaks up in the early adulthood. That's why all the sports persons will be in the age of like 18 to 30 years. It declines by about 1% every year. After 30 years, especially after 30 years, it declines by 1 year. And after that, due to the reduced maximum heart rate, muscle mass, and cardiovascular efficiency. Of course, 220 minus age, ultimately, if you become 60-year-old, your 220 minus age will be minimum compared to the 20-year-old male. The 20-year-old male, 220 minus age will be 200. But you become like 60, it becomes less, 161. So definitely your maximum heart rate reduces, ultimately affects the VO2 max. And muscle mass means the field where the oxygen is supposed to be used, right? That itself, the muscle mass, there will be reduction based on the age. And cardiovascular efficiency will also be reduced. So that's how it affects the VO2 max. So please keep in that mind. And gender, of course, men usually will have 10 to 20 percentage of higher VO2 max than women. Why? Because men used to have a larger muscle group and heart size, hemoglobin level, etc., etc., etc. I mean to say fat level, everything, right? So these are the difference. And that means next slide, please. The other two factors which influences are the training. Of course, sports persons, or if you are sports specifically, if you are training yourself, definitely you will have good VO2 max. Endurance trainers will have good VO2 max compared to the strength training people, right? Increase in stroke volume, cardiac output, capillary densities, muscle mass structure, differentiation, numbers of increase in the mitochondrial numbers will increase. If you are training a person with endurance, your stroke volume increases. So definitely all these things contributes for a better VO2 max in a trained people, especially you are trained for endurance. You know that, right? If you are becoming an endurance trainer, if you are giving an endurance exercises for a person, his white muscle fibers will be turning into a bit of more towards the red muscle fibers, where it can use more oxygen. Definitely, your VO2 max will be like this. So genetics. So genetics, definitely it has a role. If you are usually thin and slender, muscle mass are less, definitely you will have a variability in your VO2 max. So it ranges around 25 to 50% of variability in the VO2 max as stated by the ACS. Right, next slide please. It is a difference between athletes and sedentary individuals and patients based on the VO2 max. One is the athletes definitely will have a higher VO2 max. Everybody knows that due to intense training, heart, muscle size, everything has a improved value. Sedentary individuals will have definitely a lower VO2 max, often ranges from 30 to 40 milliliters per kg per minute. So of course, the VO2 max value is measured in milliliter per kg per minute or lesser than that, reflecting lower cardiovascular fitness and muscle efficiency. And the patients, the special category, where VO2 max reduce the chronic diseases, whatever it is, lung, heart, peripheries, vascular system, whatever it is, definitely our oxygen delivery and utilization will be less. So we need to keep in that mind. If a sedentary individual comes, then his VO2 max, we cannot expect to the level of athletes, we cannot expect that it will be very good like that. So whatever he does, we need to accept that and we need to focus on the training. So that is what is mentioned actually. Right? So have a clear idea about these things. So next slide is like how is the VO2 max is measured. As I was telling to you previously, so one of the parameter is direct measurement, which is a gold standard one. Using a CPET is commonly used, or Douglas bag methods also we can use. CPET will have a metabolic cart and wearing a mask and doing the exercises. It will have attached with the sensors like CO2 and O2 sensors, and flow meters will be attached. And ECG will be attached. So everything comprehensive assessment you will get along with the VO2 max value also. So process like accurate, very clear values you will get along with the multi-system problems where the VO2, why the VO2 max is reduced also we can find out. Which system is having a problem? Like your source is having a problem, or a pump is having a problem, or a land is having a problem, like muscles is having a problem, we can find it out. And the only thing is, it's expensive and needs special equipment, and the trained staff is needed to conduct this test actually. We need to be conducting it in the hospital environment. That is a must if you are doing it for a patient actually. The next one is indirect method. Next slide please. Indirect methods. where we can use it commonly used in the sports field, sports area, field method or fitness test, like we can do it. Examples are YMCA cycle test, stationary bike stated by ACSF, and as well as Rockport walk test, so always known as walk 1 mile walk test, and Cooper test. It's a 12-minute walk test or shuttle walk test, whatever it is, we can call it as step test. Is Queen's College test usually preferred because 16.75 inches of step will be used and we can assess through it, and we have a lot of calculations we can test. So these tests to use heart rate, time and workload. You see the heart rate is very important over here. We need to frequently monitor the heart rate and the time and workload. We say YMCA cycle test also will be increasing the revolutions and crank speed. Rockport walk test will also be keep on increasing the speed, and Cooper test also keep on increasing the speed. Mean to say speed is the workload over here, and the steps also. So the bras is accessible and practical, very easy to use it, not much equipments are needed, not much persons are needed. It's very easy to conduct it anywhere, but it's less accurate than the lab test. Here you can see that the CPET, using a CPET in conducting VO2, you are doing a maximal exercise testing. Whereas indirect methods, not all the indirect methods are maximal exercise testing. These are all sub-maximal exercise testing, except Cooper test. Cooper test is maximal actually. Still it's considered as a maximal 12-minute run test. But the others is tests are like step test, walk test, YMCA test are cannot be considered as a maximal, can be considered as a sub-maximal only because the speed or the revolutions in the bike and the speed of walking, running or whatever it is, like it's maybe variable, it will not be consistent. That's the problem. Okay, that's why it is a sub-maximal test. Even our 6-minute walk test is a sub-maximal walk test. Right? So next slide please. So it is an estimation calculation of YMCA cycle test on a stationary vehicle, and it is how it is VO2 max is calculated. The walk rate is nothing but the resistance which is offered and the distance which is covered. Based on that, the work rate will be documented using a YMCA test multiplied by 1.8, which is a standard value. Maximum cost of cycling per unit of work, ultimate naturally calculated and kept it as a standard value. And your body weight plus 7. This is a calculation for YMCA cycle test. Another one, the next one is the Cooper 12-minute run test or the shuttle walk test or whatever it is almost similar. This is how it is calculated. VO2 max ml per kg per minute. Its distance in meters minus 504.9 by 54.73. If someone walks for 2,400 meters, let's say if Mr. A runs for 2,400 meters in the 12-minute run test, and this is how it is calculated, and its VO2 max is around 42.36, which is almost good actually, right? So this is how it is calculated. The next one is the Rockport 1-mile walk test. This is also having a very lengthy formula. We need not to calculate and use this lengthy formulas. Just need not to memorize it actually. This is how it's calculated. For example, if Mr. S is a 25-year-old female and weighs about 150 pounds and walks for 1 mile in 15 minutes and 30 seconds, and her heart rate is at the end is 140 minutes, it's the calculation, and derives 35.23 ml per kilogram of per minute of VO2 max is achieved actually. Right? So this is how it is calculated. It's also calculation for the Queen's College step test. It's a step test which I was talking to you about. Is the next one is Queen's College step test. Yes, another one is also having a lengthy formula. Then another one, that's all. These are the 4 commonly used field tests which used to measure the VO2 max indirect methods. Okay. So next slide please. These are the normative VO2 max values for the men, non-athletes, and women with women and non-athletes, like normal people. We make someone who is regularly doing his regular work, physical activity, that's all. He's moving around here and there. For them, it is 20 to 29 more than 60 ml per kilogram per body weight per minute is very good, excellent. If it is around 50 to 60, it is good like that. Okay, it's based on the age. It is having a value also. You see that 60 year plus, if you're having a more than 45 is already excellent actually. And if it is become less than 30, it's little poor actually, right? For the sedentary. Okay. The next one is the functional classification of VO2 max. It's like what you call like for how to differentiate the elite athlete and the normal person like that. Okay, if it is more than 50, definitely it's good. Elite and competitive endurance, you can go for it. That's the meaning. 40 to 50 is good, and you can go for recreational athletes, good fitness. You can have a leisure play games like people will be usually people are playing badminton, shuttlecock, whatever it is. So they will have around this value. If or a person is going for regular cycling weekly 5 days a week, he's going for like 6 kilometers to 10 kilometers, he is walking or cycling, definitely he will have a very good VO2 max. But this low and moderate will be the normal people who are walking and doing regular activities will have their moderate to low will have, and the patients we may expect it may be low or very low sometimes. Okay. Next slide. So it's a quick VO2 max interpretation for clinically focused. You see, less than 15 is critical limit actually. If based on the guidelines, based on the AHA guidelines, based on the guidelines, we can say that if a person needs to go for a major surgery, he's supposed to have at least more than 15 VO2 max. That is more than 15 ml of VO2 max supposed to be there. Ml kilogram per minute supposed to be there. Then their prognosis will be very good after surgery. Because it's understood that the patients will have a low VO2 max. Even if it is very low, then the outcome after surgery may not be very good. That's what the prognosis will not be very good. That's what it's mentioned over here. Okay, right. So based on this VO2 max, the major surgeries, especially liver resections, liver transplants, any abdominal organ dissections, and the next one is cardiac failure, and whether they require heart transplant or not is decided based on the VO2 max CPET values actually. So all these things are very important in the major surgeries and major system involvement and clinically focused. These are the things, right? So, okay, right. We have few patients, we did some patients for a major, usually patients will be coming for VO2 max measurement mainly for before major surgeries actually. If we have 20, we'll straight away we'll give the fitness, right? Next slide. Okay, there is one more important is why it is important to us physiotherapists. It is important in the rehab areas. As a cardiovascular respiratory physiotherapist, I'm interested in assessing this VO2 max for my pulmonary rehab patients who are not around oxygen. If they are already on oxygen, I cannot measure. It will not give a proper value. I can do the 6-minute walk test, I can indirectly calculate, but it will not be very optimal value. But anyway, but cardiac rehab patients who are not on oxygen, even pulmonary rehab, cardiac rehab, definitely it is very much applicable where I can take this VO2 as a very clear-cut assessment parameter as an outcome measure. Very clear-cut outcome measure. I need not to bother about any other outcome measures. This itself is enough because VO2 max is good means lungs, heart, peripheral circulation, pulmonary circulation, and your muscles. Everything is fine. Athletic testing and disability evaluation also we can use it. Athletic testing, yes, we need not to be used as VO2 max in a clinical setup where clinical setup parameters are not all the parameters are required for the VO2 max assessment if you are doing for athletic testing actually. Right? Then disability assessment also we can do it for the exercise prescription purpose. Okay. All right. So it becomes an important outcome measure in physiotherapy. This is the reason the best and most reliable indicator for cardiopulmonary fitness, especially the aerobic capacity and endurance. We'll be writing in our problem list the patient has a poor endurance, decreased endurance, and decreased aerobic capacity. By what means we use to assess this aerobic endurance or capacity? By means of 6-minute walk test, isn't it? Definitely, it's a submaximal test. Patients can be used. But the best one is the best, really the best one is the VO2 max, where if it is not possible, then we need to use for the other tests. Functional outcome monitoring, validate the effectiveness of intervention programs and quality of life. For example, pulmonary rehab programs outcomes or cardiac rehab programs outcomes or whatever it is. And risk stratification and prognostics tools actually. So how much risk the patient is having by means of VO2 max we can calculate, especially the post-operative recovery. Individualized exercise prescription and like preventing the overexertion, reducing the injury, and optimizing rehabilitation outcomes and adherence, and motivational tool. It can be used as a motivational tool. For example, sometimes we maybe hear about a normal individual is going to the gym and suddenly doing the exercise at the gym and suddenly had a heart attack and fell down and passed away. So why? Because without proper assessing his original capacity, the regular actual capacity at the gyms or the health clubs, they are giving an exercise over his limit, more than his VO2, more than his heart rate limit, then this might happen. So it is advisable for everyone should have an outcome measure as a baseline. How much VO2 the patient is having or the person is having, a normal individual is having before going to the gym or exercise or the rehabilitation program. And after that, based on that, you prescribe the exercises, a proper prescription will lie on the VO2 max, and we can assess it and we can increase it gradually and we can assess after a certain period of time. We'll have a very fruitful result in your hand. So this is why it is important as an outcome measure actually. Right? The next one is okay. Right. So this is just an additional extra thing. We may be confused with VO2 max and METs frequently. I used to get confused when I started like cardiorespiratory physical therapy. What's the difference between this METs and VO2 max? And METs is metabolic equivalence. Of course, it's also considering about the metabolic systems. That is the muscles actually. VO2 max is also contributing about the metabolic system. So what's the difference between these two things actually? So it's explained in the next one. So it is a metabolic equivalent of the task. VO2 max is a maximum oxygen uptake. Next slide, please. So the definition of this VO2 max, we all know that how much oxygen that you are using it maximum on the previous slide. METs is a unit representing the energy cost of physical activity. Right? This is the METs actually. But METs is VO2 max is measured in ml per O2. That's based on the body weight. But a METs is a value. It's a resting oxygen consumption. 1 MET is equal to 3.5 ml of oxygen is used in your body. That's what the 1 MET actually. So it measures the aerobic capacity, VO2 max, but METs is not measuring the aerobic capacity, but it's about the exercise intensity, workload. That's what the difference. So it can maintain the classification of activity based on the its intensity of the activities. We can classify the physical activity based on the MET. So the formula is 1 MET is equal to 3.5 ml of kilogram per minute, but whereas VO2 is divided by 3.5. Mean to say, if a VO2 max, a person's VO2 max is 42 ml per kilogram per minute, but your MET will be 42 divided by 3.5, so 12 METs. Mean to say, you can allow the patient to do the activities until 12 minutes if you wanted to give 100% of intensity of exercises. Do you understand? If you wanted to give 100% of intensity for a patient or a person who are having the VO2 max of 42, you can go up to 12 minutes of activity. That is what the meaning actually, right? And we know that what are the activities are having 1 minute, 2 minutes, 3 minutes, 15 minutes, and 12 minutes and all. So 12 minutes is almost like a competitive activity only. Leisure and competitive activities can consider. So these were the difference between VO2 max and METs. So ultimately, METs, by prescribing the METs also, we can calculate indirectly the VO2 max. That's what the idea. Okay. Alright, so these are my references. Next slide. These are my references. Fine. So just a quick recap or summary of this, the topic which I covered today. So we have covered about what is VO2 max actually. It's very important. VO2 max is an important one. And we need to, what is VO2 max? We need to know the definition and what are the physiological things that is operating behind the VO2 max. I'll explain the diagram. And what are the various methods of assessing the VO2 max, the indirect and direct method. Direct methods of the VO2 max is assessed using a CPET or Douglas bag method, where you need to have a metabolic cart, where it's the sensors which needs to assess the CO2 and O2 by means of exhale there and inhale there. Then you have indirect methods. We have a field fit tests. The example of road field test I explained. Then the other one is like based on the context, patients and age, sex, fitness levels, what are the variations in the VO2 max and normative values we discussed and why it is important to our knowledge, our physiotherapy knowledge I explained here. Right? Hope that's all about my topic. Thank you all. Thank you. If there is any doubts, you can clarify now. Still we have some time actually. Is it audible?
Yes, sir.
Okay.
Participants, unmute yourself and ask questions directly or else put questions in the chat box.
Yeah, I have a doubt. Yes, please.
Sir, in hospital settings, after patients post surgical recovery, some
Yes.
physicians are not calculating the VO2 max, so patients are dying on table. What's the reason for that?
No, it's not like that. Actually, if we consider Coimbatore, we have only VO2 max calculation. Like we can do it only in KMCH, I think, and another one is one more hospital also having. Because the equipment itself too costly and it needs a specialized personnel to train staff need to be conducting the test. So not all the time it is available. If you take like in olden days, the anesthetist will check for before a major surgery. If you are able to climb two flight of stairs or three flight of stairs, you are fit for the surgery. Like that, they will say it like assessing that. So at least instead of assessing the VO2 max, definitely they will be assessing the patient's fitness, whether he is fit for the major surgery or not, through some other measurements actually. Some other physical measurements, or like they will be doing a pulmonary function test or the stress testing. At least they will be doing it all. And based on that only they will be progressing for the major surgeries especially. Yes. Unless otherwise, if it is a very emergency, then they will not, means it's an elective surgery, definitely they will go for some basic things and they will go for the surgery unless it's emergency.
So sometimes patients are not willing to go on for pre-surgical VO2 max exercises and sort of protocols. What can we do for that? Is there any alternatives for that?
That's what we can do a field test, even 6-minute walk. If not able to walk, also we can at least a 12-minute walk test, a 2-minute test are very difficult. Means we can go for 6-minute walk test and indirectly we can calculate that.
Okay, sir.
Yeah. Thank you.
Thank you. Another doubt.
Yes, please.
Sir, in gym, some people they are not training appropriately for VO2 max. They're actually going for strengthening training sort of things. How can we guide for them, sir? Is there any protocol for that?
Yes. Actually, for basically, whenever if someone is joining in gym, I am not having much exposure in gym, but part Q, at least physical activity readiness questionnaire they have to collect. Mean to say, at least in that, the patient will say that he's having some issues in the cardiovascular system, he's taking some medication, all these things, we'll have some idea. Then, before starting up an irregular program, they should have some kind of a basic fitness. Even strength training, they should measure 1 RM or 2 RM, 10 RM or whatever it is. And based on that, our endurance training, basically just calculate the basic capacity of walk, how much you usually walk. Daily activities like you are able to walk for 5 kilometers or 2 kilometers or 1 kilometer. If a sedentary person goes in, he's not at all walking, he's always working in the sitting environment. If suddenly goes and you ask them to walk for a 10 kilometers, definitely he will die. And especially walking, instead of you are making him to run, definitely it becomes difficult actually. So that's how some kind of a basic things they need to assess. By means of a proper physical trainer or a physiotherapist or some kind of a guidance are needed for the gym people so that they can conduct their gym in a proper way and without any harmful things to the clients, their clients.
Because why I'm asking this, because I was in a gym for 2 years.
Okay.
Training myself. I trained cardio separately instead of training strengthening in some parts. Weekly I will train 3 times cardio and 4 days for strengthening.
Okay.
I recorded myself. In gym people, trainers are not emphasizing people to train VO2 max like do cardio for heart health. So I'm asking them.
Definitely they cannot be aware of those things, like because if we are studying a proper exercise physiology or exercise physiology courses or related strength and conditioning courses, something we will be knowing it out, but because of cost efficiency where it is available to ask them to go and check also, they may not be knowing actually. So that's why that things may happen.
Sir, where we can learn exercise physiology, sir? Is there any academies or courses available for this?
No, you have the MPT syllabus itself, exercise physiology is there. There's a basic exercise physiology is more than enough.
Okay, sir.
Yeah. Okay, thank you very much.
Sir, one more question I have been asked. Could you please add few points about VO2 max versus SpO2? Ilamadi asked.
Sorry. VO2 max versus
SpO2.
SpO2.
Yes, sir.
Saturation, right? SpO2.
Yes, sir. Saturation of oxygen.
Hello?
Yes, sir.
Am I audible?
Yes,
It's
sir.
saturation.
Yes, sir.
Saturation. Okay. No, saturation is a very peripheral measure actually. How much oxygen hemoglobin is winding around by means of sending a IRR rays, it picks up. It is like a peripheral measure. And if you have a local compression, if you have a local injury or whatever it is, it may get, if you are having a nail polish, if you are having a cold extremities, it will get affected actually. So VO2 max is a true value where once you inhaled oxygen and exhaled oxygen, you are having arteriovenous differences, it can able to calculate. But SpO2 is no, it is a overall peripheral value only. Sometimes SpO2 will be good, but if you take a ABG and your PO2 may be very less sometimes. So that is a clinical peripheral value actually. So VO2 max, when we are doing a CPAT testing, we will be calculating, we will be assessing the SpO2 also, but it's not very closely related to the VO2 max. If you are having an anemia, definitely you will have a low saturation because your hemoglobin amount will be less actually. So it's a clinical parameter.
Thank you, sir.
Yeah, thank you.
Sir, another note.
Yes.
Sir, in preterm babies, I'm asking about pediatric cardio we have after babies in ventilator, after weaning from ventilator, what we can do for increase in VO2 max, sir?
Okay. No. Sorry. I'm not very much into pediatrics actually. Maybe I'm not a better person to ask and answer this question actually. I'm out of pediatrics for long years, like 15-20 years. I'm not into pediatric patients actually. Where we are having pediatric patients for pulmonary rehab, but mostly the age of more than 10 and cystic fibrosis and all, for the fitness purpose they'll be coming in. I'm not into acute care and all. I'm not much into that. Sorry.
Okay, sir. As per you, how can we calculate for them, sir, after age of 10?
Yes, it's a very good question actually. For that ACSM guidelines, the text, the exercise testing and prescription book is there. For that, for exercise prescription for pediatric age group is a different chapter itself. We cannot apply the same adult calculation to the pediatric people. It has a different calculation. We can go through that ACSM guidelines for exercise testing and prescription actually.
So why I'm asking this because in some cases, preterm babies can have ASD or VSD sort of things, or acute distress syndrome. So
Yes.
I'm asking because they don't have much VO2 max after some time.
Yes. Actually, for here we haven't get any till my now. I haven't get any kind of cardiac transplant patients who are requiring for the pediatric age. But in that case also, we'll be doing the VO2 max assessment. Actually, the centers which is very familiar for the cardiac transplants, they are conducting the VO2 max even for the patients who are undergoing for the heart transplants. We are doing it for adult patients, but heart transplant patients for pediatrics. Definitely, they have to go for a VO2 max assessment before their transplant. Actually, yes, correct.
Thank you, sir. Thank you so much for clarifying.
Thank you. Yeah.
Any further questions?
Thank you. sir. Thank you, team.
Thank you.
Yeah, thank you. Thank you. No problem.
Okay. So thank you so much, sir, Sivaguru sir. Really, it is an awesome presentation, and we really honored and privileged to have you. And one more question we have right now from Lakshmi Priya Rajashekaran. Sir, is it right to assess VO2 max post CABG or ejection fraction? Can you please clarify?
Actually, post CABG, no need actually. Immediately post CABG, they won't do. EF is better actually. The EF, they'll be assessing after the surgery, third day of surgery and fifth day of surgery before the discharge, they'll be doing it. But immediately after CABG, will be once the patient is entering into the second phase of cardiac rehab, we can assess the VO2 max for the proper prescription of exercises. As a home based exercises or outpatient based exercises, we can definitely go for VO2 max assessment. Nothing wrong in that actually.
Yeah.
I hope I answered. Yeah.
Yeah. Thank you, sir. Thank you. Extend my heartfelt thanks to Dr. Shivaguru sir for such an enlightening and thought-provoking session. Thank you, sir, and best wishes to you, sir.
Yeah, thank you. Thank you so much for KMCH College of Physiotherapy for organizing this, and thank you. Thank you for the invitation. Thank you.
Thank you. Sir, are you in line?
Yes.
Sir, one more question. Pratik has asked 50% is needed for ejection fraction. Pratik, can you?
Yes. Actually, yes. 50 and above is usually considered, but below 40 is considered as a poor ejection fraction. Below 40, 30 and all is very severe ejection fraction, very poor ejection fraction. So above 50 plus is good actually.
Okay.
Actually, post surgery, if they are having 50 plus ejection fraction, we will be making them to walk the steps actually. Before getting discharged, step climbing, slope walking, and all we try based on this EF, which is calculated on the 5th day or 7th day before the discharge. Yes.
Thank you, sir. Hope it's answered.
Yeah. Thank you so much. Yeah.
Thank you so much, Pratik. So you are asking good questions. Thank you.
Yes, sir. Thank you, sir. Thank you, team. Thank you, team.
Thank you. Sir, Shanmuga Priya. Sir, are you in line?
Yes.
So Shanmuga Priya asked ejection fraction doesn't improve immediate post-op. So
Depends on the previously how much they had a problem, how much ejection fraction was very low. Based on that, it will be slowly improving because once after they resetting the conduits, usually the heart will have some time. It will take some time by its own healing and its remodeling because enlarged heart, cardiac changes, everything will change actually. So that takes some time to overcome its whatever the ejection fraction which is lost, to overcome it takes some time actually. So immediately after surgery, it will not improve.
okay.
Thank you, sir.
Thank you.
Any further questions? Pratik asked again one more. Adaptation needs. Okay, is it answered?
Adaptation is needed, sir, after post-op. So ejection fraction will be good.
Yes. That's what takes some time. Yeah. Some improvement will be there, not like very good one.
Yes, sir.
Yeah. Thank you so much.
Thank you.
So may I leave? Thank you.
Yes, sir. You can leave, sir. Thank you. Thank you for.
We are coming to the last lessons of Faculty Development Program. Last but not least, it's my pleasure to introduce today's speaker, Mrs. Sneha Sushan ma'am. She completed medical physiology. She is working as an assistant professor in KMCH College of Physiotherapy more than 3 years. The floor is yours, ma'am.
Ma'am, you can share your slides.
That is your question. Start.
Okay. Sir, am I audible?
Yes, ma'am, you are audible. Your slides are
Yes.
visible, ma'am. You can go ahead. Yeah, thank you.
Yes, ma'am.
So we have reached the last session of this FDP program, and let's see what is new in this era and what is the new technology in this. My name is Neha Susan Sataria, Assistant Professor in Physiology, KMCH College of Physiotherapy, Coimbatore. First of all, let me extend my heartfelt gratitude to the management, principal sir, vice principal ma'am, all the faculties, especially the organizing secretary, Professor Brahmada ma'am, and organizing committee. Now we will move to the session and we will see what is the new technology, what are the wearable technologies and how to make use of it, what are the types, how to make it. And in this, we are going to see next 1 hour, we are going to see which are the technologies, what are the types, and what are the methods, how to use it, what are the significance, what are the reliability, and what is the specificity. And in that, mainly when it comes to the healthcare system, what are the uses, what are the advantages? Hello, sir, am I audible?
Yes, ma'am, you are audible. Pratik, what happened?
Yes, ma'am. Okay.
Isn't
So when it comes to the healthcare and patient care, what are the advantages of this wearable technologies and rather than the traditional conventional methods? So first thing is it is less time consuming and less money spending. And when it comes to the healthcare center or a patient center, we are not preferring this top and high-end technologies for the critically ill patients, but rather a hemodynamically stable patients, walkable patients, or even in the fitness tracking. So first thing, it is continuous monitoring, 24/7 it is monitoring, and even if the patient or the person is far from the primary location, you can monitor it. It collects all the data and you can analyze it in your own smartphone. And it improves diagnosis, enhances safety, also increases community participation and maintain independence, especially in old age people. When it comes to the community-based research, gait labs we can maintain, we can see, monitor how they are improving, and we can measure it, we can do research and medication titration, how much they need, we can control. And this is an experimental study and a project was conducted in Scotland, especially in old age people and in the home care nursing centers. They gave the wearable access devices connected to a smartphone. It was connected to the Wi-Fi, their network. And finally, it was monitored by the either healthcare professionals, researchers, and the immediate close family members. And in this study, in this setup, they found it is more profitable in the sense you have less hospital stay and they can go to the nursing homes or the homes and in their own home or in the home they can continuously monitor. If needed, they can get a healthcare access. So basically that saves their time, that decreases the hospital stay, also it improves in terms of GDP. And when it comes to this wearable technology, a lot of things are available now. Most of them are very common nowadays, wristband, headband, all these things. And most of the parameters, what you can see, one is ECG, electrocardiogram, one body temperature, blood pressure you can monitor, respiratory rate you can see, oxygen saturation or your SpO2 levels you can see, and the surface EMG biomarkers, especially sweat sensors, sympathetic and parasympathetic balances you can monitor. Now, when it comes to the uses, what are the main uses in this new technology when you are using it? Mainly for the movement monitoring. So, body position, what are the movements, activity monitoring, energy expenditure you can monitor and you can calculate also. Geolocation, track activities, it helps to localize people in need of urgent clinical care, and also it fuses with the sensors embedded in the environment, merging with the survey data, and it can give the data anytime you need. Then when it comes to the wearable technology, mainly two things we can classify. One is either inside the body, on the body, or outside the body, where it is placed, where the sensor is placed. And again, you can classify it ambulatory systems and cloth-based system. Ambulatory system, for example, ECG monitoring, in that they will keep the leads on the chest. It will be attached to the chest of the person, and there will be a small device in his pocket, and from the small device, the signals that sent to the dashboard, you can monitor the ECG activity. And in the cloth-based system, what is happening is there is an inbuilt sensor inside your cloth or in the shoes that detects all the signals, gives to the dashboard or a computer that analyzes and gives you the record. This was the olden days one. Now we are not using it. In this, you can see the 6 chest ECG leads, and that is connected to your thumb. Thumb basically shows your SpO2, the hand probe, and that is connected to a small device that you can keep it in your pocket. That gives signals and that monitors the graph, and that is ambulatory. When it comes to the wearable system, it is more better. Why? Because you can move more. So nowadays there are different forms, either in the glove forms or ECG or chest band that assess your respiration, motion control that sensors you the information to your Bluetooth or your GPS, and that one connected to your internet that gives this information to the first responders. So especially the people who are far or remote, or especially those who are living alone, living with assistance, this gives a better idea. Now, these ones are new technology. These are just newly involved, but the reliability we have to test. Wristbands are there, pods are there, then jackets are there that detects your motion, and even in the shoes they have embedded sensors to analyze your gait. This is just an analog of your what is happening inside this, and in this you can see it is a device for wearable electronics, and it is a nano method, so it is small and lightweight. Low power consumption, it supports more sophisticated display, and you can have an input requirement. And it is a prototype that shows a jacket. Basically, in this sensors are there the two bands. Basically, these two bands called the respiration bands that gives your plethysmography. Basically, the plethysmography is a test that to analyze or to measure the lung volumes. So this is device basically measures your lung expansion during inspiration and expiration. And one more is your speech recognition. This one most of them are familiar because nowadays we have at home Alexa forms and all. So it detects your motion, it detects your speech, and according to that they will give commands what to do. And always in the graph you can see what you are expecting. The ideal graph is little above that what you are getting. So the reliability is little less, but we have better reliability than the previous. Reasonable accuracy and better algorithms are being developed to get a best output. Now, gesture recognition, whether it is hand movement or face movements, and good precision for higher samples, well-established algorithms are currently available. So basically, based on your hand movements or your face movements, they can detect what you are telling, and they will give the commands. When it comes to the ECG and the EMG, first one is the electrocardiogram, that most of them we are available in the wristband also, very common nowadays, and in the sensitivity almost 99%. That means it has a better sensitivity and selectivity when comparing to the normal ones. And EEG, it is little less, but still it is more efficient and useful. And in that you can see seizure detection, band power extraction, and heartbeat detection. The advantages are you have high sensitivity. It is most of the time it gives accurate values, power, performance, and a detection rate. When it comes to the connectivity, this connectivity Bluetooth, most of the people we are using nowadays, and we call it Bluetooth Smart. Why? Because it has a wider range and it has less error. And most of the time we use it for fitness tracking. Anytime we set up a goal, so for tracking a goal, whether you want to lose weight or gain weight, we all use this Bluetooth connectivity. And what is the impact on healthcare? So the first one is fitness tracking and improvement. You can monitor every day or every minute, 24/7 it is available, and all the data from the time you started using it, it will score, it will record in the app. And management of hospital organization, so that you know who is more sick, you can prioritize the patients. Personal drug dosage tracking, especially the people who are taking tablets for a really long time, you can monitor it and you can titrate the drug. Telemedicine is especially for the people who are far from the primary health care center, they can access it. Rehabilitation, you can see how well they have improved prognosis. And healthcare big data, in that you can see a person's all the data. Instead of the hospital setup, they are moving from hospital to hospital. The device store all the data for the past years. And when it comes how it is tracking, you have a device, you have to wear it, and either it is hand worn or body worn, whichever you are preferable and convenient. And this, once the machine is on, it tracks all the information, whether it is physiological or personal activities, biological parameters, your performance, all day-to-day activities. And that data collected, for example, heart rate, stress, obesity, sleep, calories, oxygen saturation, and blood pressure, that collects and monitor. Once the data is recorded, they analyze and give you the interpretation. So especially the apps when we are using, that will give an interpretation of what data they are getting. Also sometimes they will give you suggestions what to do, what not to do. This is a very common one that they use. It is called a run scribe. Basically the purpose is, it is a small device, a small pod attached to the shoes, so it is for the gait lab or the gait analysis, and it is very lightweight, 15 grams, and very small. In this one is connected to your device, and in this you can measure all the parameters, for example pace, impact, braking, and pronation velocity. So all these parameters it is collected and it is recorded. It is one of the most commonly used 1 million kg challenge, and this device, most of the people they use it for the daily fitness tracking, and in this they have one of the most popular. In this mostly people use for weight balance or weight gain or weight loss. And the apps you are familiar, iDat, MyFitnessPal, RunKeeper, Lossit. This apps you can install it and you can monitor it. And the wearable fitness trackers, for example, Job One up to 24, Withings Pulse Auto, Samsung Gear Fit, Nike Fuel, Garmin, Apple Watch, and these all are most commonly available nowadays. Now, how do they collect, how do they process, how do they display? So mainly first they collect the information from the sensors, continuous tracking of physiological data, and then whichever part, hand, head or body one, and sterility. They maintain it and they collect, process, give to the processing, identify the priority patients according to their needs, and they give a better diagnosis. And in the display, you can see efficient staffing for nurses and doctors in a hospital setup, avoid useless of displacement of staff. So basically your resources you can manage and use what is needed, what is not needed. Also you can prioritize. Now, how to use this wearable technology in personal drug dosage tracking? In this first haptic, that is touch sensation, visual or sound drug reminder, and drug taking devices for the elderly. Basically that gives you a reminder every time when you want to take. And wearable technology and healing devices, insulin monitoring, when to take, how much you need to take, and there is insulin nano pumps that is available nowadays. And there are some apps remind you to take tablets or water, and Scoutling wearables for baby monitors for baby movement detection. Also, especially in the febrile conditions, when the temperature it assess and tells. Now, this wearable technology, you can use it combined with the telemedicine. So, nowadays, especially when the COVID time was there, we were all talking about the telemedicine. So, the purpose is patient is in one place, the healthcare system is in another place. You don't need unnecessary traveling, all this expensive or unnecessary time wasting. Instead, where the person is in home or in a nursing home, wherever it is, from there you can have a close monitoring access to it, and the people, healthcare professionals, they can monitor it and they can give the suggestions what to do. And this telemedicine is applicable in all the fields, for example, telepharmacy, teleradiology, telecardiology, telepsychiatry, so that one we can implement it all sectors. When it comes to the rehabilitation, this is much more useful because finally we have to make them independent to move. At the same time, they are in close monitoring. And in physical activity tracking to evaluate improvement, better identification of physical weakness, and optimized HCI control. Basically, HCI means host control interference, voice control or non-invasive tongue control, and sensors are there to compensate the loss of sight or speaking, and e-legs to help the paraplegic to walk. And in elderly, the posture tracking to avoid falling, and retirement houses, better accommodation to wearable computing. So basically, this makes them a better life. It offers them more movement. This was a project. It was funded and done by the National University of Singapore. Here, basically what they're doing is, for the blind people, they have implemented motion detectors. So using this, it is a better guidance for them. Now, if they are asking if the wearable technology is 100% safe, it is still under developing. So, almost it is done. We have to do a little more, but especially when it is critically ill, we usually don't rely on 100% technology. We need people to monitor. But someone who is stable, they can walk, they can stay at home. You can definitely use wearable technologies, monitor the parameters so that you can monitor how well they have improved. Now, when you see the statistics in the past years, in the recent years, the market has grown up. So basically this graph shows there is a huge demand for the wearable technologies in the market. So when you see 2024, almost $94 billion have spent in this market. So basically they are developing better technology, better devices, so for the better healthcare system. And when it comes to the healthcare altogether, in that estimated 7.3 trillion in 2012, we have done 7% of estimated annual growth. Personal care consumption have increased, reached up to $2.2 trillion in 2017. Telehealth patients to nearly 2 million by 2018. Healthcare wearables are almost increasing the demand. Approximately 30% of wearables market value, already $1.1 billion in 2014. So basically this values shows there is a huge demand, increasing demand in the market. Now, is this the right time you can switch to technology, or still you want to use your traditional conventional methods? So there are a lot of advantages what we have discussed now, and what is the best part of it? It improves customer value proposition, numerous features enabled by scaled sensors and displays. So most of the time in a single gadget, you have more than one parameters to analyze. Established adoption of smartphones, tablets, and products close to the wearables. So it will give better life experience to the people who are not even in touch with the smartphone. And rising life expectancy, more seniors and chronic diseases. Decrease in the length of hospital stay, so it saves your time, it saves your money. Long-term care. Interconnection of wearables when it comes, how does it work? So basically all these are interconnected. You can have a wristband or you can have run scribe. We have explained Jawbone, Polo Tech shirt, Google glasses. So all these are sensor embedded technology that you can use it using any one particular application in your smartphone that is connected to your computers or smartphones or tablets, and this information is stored in the cloud. So the best part is, even after a few years, this data will be still there and you can retrieve it. And how to use it? It is very easy to use, very convenient. Most of the time it is plug and play, compatible with all the wearables, bounded to an ergonomic application, connected to the cloud to save and manage data. When it comes to the conclusion, we can conclude that the wearable technologies have evolved a lot and it can give a better analysis and more reliability and more specificity. It is real and meaningful, and there are maybe there are some more advances in this field so that you can have a more reliability in this. Thank you.
The floor is open for question and answer session.
Ma'am, I have a doubt regarding telerehabilitation. In some cases, patient with wearables, we can do rehabilitation, we can do telerehabilitation.
Yes, sir. Sir, what we are suggesting is, someone who is critically ill, we will not leave them with the technology alone. You need a close monitoring, you need a person. But if someone is hemodynamically stable, vitally stable, and you want to know the parameters, all this, and then you can go for it. So always we prefer you cross-check both, because if there is something wrong with the gadget, it may show the wrong result that we don't want.
Another in some cases, patient is not compatible for wearable device. What we can do for them? Like bioprosthetic arms, wearable clothes like polo t-shirts, sort of devices what we're using. In some cases, it's not capable for patients. What we can do for them, like sensitivity issues.
Sir, actually, there are some more people, those who are not adapted with the smartphone and the new technology. So especially the old people or someone who is not so fond of the technology, they still prefer the old method or the traditional methods. So you can go for it, no problem, nothing wrong in that. But you can always tell them what is the advantage, what is the best part of it, and you can try to convince them, but it is not mandatory. It is their choice which one they want to do. So if someone who is not at all coping with the wearable technology, it is okay, you can go with the normal ones. But nowadays it is very comfortable. So even for the pediatrics or the special population, we have a better ones. Maybe it is little expensive, but you can track them continuously. Also, you need to teach them how to use, when to use.
Using these kinds of devices is ethically not professional, because we are collecting data and storing in the cloud. Is it ethical for us? We can use the data. Is it ethical?
Normally, whichever devices you are using for the patient, that will be connected to a particular application. So this application, they have the license to do, so they are storing. So we are not collecting it. The app is collecting. Anytime you can see it back.
Asking this is comes under the medical legal section, so I am asking that.
Sorry, definitely you can't reproduce it somewhere else. That you need permission, you need the consent, but you can monitor it how well it is going.
Yes, ma'am. Thank you.
Thank you, sir.
Susan ma'am, one more question. Lakshmi Priya asked, can you brief about the disadvantages or contraindications of these devices, ma'am?
Okay, sir. Yes. Sir, it depends upon each device because now in the market we have a lot of devices available. Even starting from the 500 rupees, you can get a wristband or less than that. So, depending upon each company or each one, which company it is producing, its reliability, efficiency, and all it matters. So, for example, even if you take in case of wristband also, if you count the steps, you can see the difference. What is the real count and what is the recorded count? So, what I'm suggesting is there are a lot of options in the market. You can always go back and see the review, or you can see the reliability and do it. So, for the same purpose, or if you want to monitor the steps, or for example, if you want to monitor the heart rate, you want to monitor the blood pressure. For a particular purpose, you have a lot of devices. You can go back, check, and one demerit, I mean, the cons what I'm telling us, a lot of devices, each one will show each result. So gadget to gadget, there will be some little bit variation. There will be still little, a small percentage of less than 5% error will be there. So that and all you have to cross check. You can't completely rely, you can't just blindly take the value.
How can we target some people is not using wearables because some people need so what we get for that?
Sir, there is no point we have to do targeted and we have nothing like that. If they are convenient, if they are comfortable, and we can tell them these are the advantages if you use it, then we can go for it. It is not a mandatory that we have to force them, you have to use it. Say, for example, if you have some fibrillation, you have arrhythmia, the doctor is suggesting you to have an implant pacemaker. That is not an optional. You mandatorily you need to have one, so you have to keep it as a prosthetics. This is not a mandatory one. It is up to them how well they are comfortable, convenient, they can use it. Always you can tell them this is the advantage you can monitor.
What if it becomes compulsory to use? Because I'm asking some example. For example, if patient is really needed, how can we approach them?
Sir, sorry, I didn't understand.
What if people needs compulsorily?
We couldn't comprehend your question.
See, Pratik, I think you're asking what if people need it compulsorily. So,
Yes, ma'am.
see, we have so many things so that the patient as a client has a choice. Like we are giving choices to the individual or the patient. So they decide what they want because it is a collaboration between the therapist and the patient. It's not like a therapist driven treatment or a patient driven treatment. Nowadays, the scenario has completely changed. So somebody wants to you go for this, especially in the domain of physical activity and fitness. This is used so much as ma'am said. So for physical activity training purpose, they can't come daily to hospital or our physical therapy department. So in their home setting, we can use lot of these devices to improve their physical activity, thereby their health and adherence towards the physical activity whichever they are doing. So the choice is patients as well as therapists. So it is like we decide like what will be the best. Patient decides what is suitable for him, what is effective for him. Yeah.
Can
Well, why
I
I'm asking this because I have a long time hypothetical question like what if people need compulsorily to use these kinds of devices?
See,
I'm not the person to
yeah, I understood. See, now we had a COVID situation. So that time we were more towards use of these technological devices. So it is the environment which decides everything. So maybe you have a situation where you might be inclined to use. Most of you might be inclined to do the tele rehabilitation and tele devices might be the need of the heart. So situation may can go that way also. Yes, I think yeah.
And I'd like to add one more point, which is the patient has ultimately right to take a treatment. So if a patient is not willing to take treatment, even we could provide treatment also. We should not give. until unless patient cognitively sound. If patient is not cognitively sound, then their relatives, the second round of people, they should give a consent. Then only we can give.
Yes, sir.
So whether it is, we know that we have to the role that we have to play is we have to explain what will happen if they take the treatment and what if they are not taking treatment, what will happen. Those things we have to give an education, that only we can give. So until unless patient give consent or patient cognitive decline, the patient's relative can't give consent, then we can't move further anything.
So there is an old question. 1 second, Pratik. There is an old question by Elamadi. Ma'am, can you please explain about usage of Google Glass in medicine? Have you answered this, Sneha, ma'am?
No, not yet, ma'am.
Google Glass means that is VR or Google Glass itself or just
Actual Elamadi, ma'am, are you there? Could you specify your question? And we do have another question by her. Can you add few more points about gesture recognition devices?
Yes.
the haptical.
Yes, ma'am. Yes. Ma'am, you have mentioned Google Glass. So one of the devices used in medicine. And what is the purpose of Google Glass in medicine? That is what we asked. Ma'am, actually, we have Google Cardboards, so that will give you a video kind of appearance, so that we can use in pediatric population. And one more thing is that will give you a little bit more better motion detection, especially the people who can't see clearly at night. They will give you a little bit guidance. So this is for the people who are a little disabled or they need assistance. Then you can go for it. Okay, for the visually challenged person like that, ma'am. Ma'am, for a visually impaired or challenged people, we have special devices that also with the movement or the touch sensation we have that we are, there are a lot of things already available in the market and still there are some things they are developing. So basically that helps them to know better. Okay, well, thank you. And also, what about the gesture recognition devices? Gesture recognition in face and all they are using in the western side and all. So especially the people who can't speak or like very poor in a bedridden condition, by seeing the movements, they can understand what they are trying to say or the basic needs. So that is one method they are using. I mean the technology they are using. So this are but in India it is not available, right? Not yet. Okay. So we have to bring more about it. They are still developing it. Thank you so much. Thank you.
I think Nirmala Devi had asked, ma'am, could you exactly define about age group of pediatric eligible for tele-rehab?
In the ma'am Nirmala Devi ma'am's question, I'm just want to answer. In the current scenario, we are not doing any telemedicine without seeing the patient. So what we are doing is first we need to go approach the doctor, see what is happening. Then the follow-up only we are doing in telemedicine, not directly doing prescribing drugs in WhatsApp they are getting from medical shop, not that scenario. So you have to go consult a doctor, see what is happening, and then the follow-up part only they are doing. Also, when it comes to the pediatric population, we need someone, an adult person to recognize, know what is happening. We are not directly giving. So it is again up to them. You have to educate the parents or who's with them, the caregiver. Then you can go up to some extent.
Pratik, are you there? Are you going to put your question?
Yes, ma'am, I'm here. Ma'am, another question. Nowadays, people are trying to getting cheaper things for like they're getting cheaper watches. They can't precisely note down the O2 saturation or heartbeats, such a things. What can we do for them, ma'am? Some people are.
Sir, I understand your concern. Actually, if you are healthy, stable, then I am not really worried about your steps or your saturation. But if you are acute sick or chronically sick, or you really want to know what is happening, then you will definitely go for a better devices. So it is a personal choice what you need to prioritize, whether your health or your cheaper options.
In some cases, patients are not aware and they're having some sort of high hypothetical question like, I'm so fit, I'm watching my watch, I'm so healthy, but why I am in this condition? They're asking what we can do for that.
Sir, I personally feel we don't really need to push anyone. So it is up to their choice. Also, one more thing, we are not suggesting any brands that this brand is better than this one. We are not doing any marketing. So it is all up to them. How do they feel? How much they want to improve? It's their will. So it is up to them. They can choose.
I'm not just marketing, right? I'm not a person to do this. I'm just asking because patients are nowadays trying to be fit, but they are not.
It's more of trial and error with the patients.
Yes, ma'am. You're right.
Appropriate for the patient, we have to go. Yeah. So then we have a question by Lakshmi Priya. Is there any device for monitoring blood sugar levels before and after exercise? Neha ma'am, do you like to answer?
Ma'am, we don't have before and after footage, but what we have is we have an implant that we usually keep under the arm. So there is a small pot that we can get in India in our shop also, that we can have a small needle. They will keep it inside, means below the arm. So basically the needle is subcutaneous. That subcutaneous needle, it is not so painful. You can keep it on the body all the time, even when you take bath. So the best advantage is it will monitor your blood glucose levels before or after or all the time, 24/7 in a day. But the glucose levels are just a parameter. If you want to know the better value, you definitely have to go HbA1c, the lab results. So this one will give you an idea of how your blood glucose levels are spiking.
Ma'am, another doubt.
Yes, sir.
Ma'am, setting up motion capturing labs are too costly or affordable in recent scenarios.
Sir, presently it is still implementing, it is developing. So definitely it is going to be little expensive. Also, you have to see how reliable it is, how efficient it is.
Yes, ma'am.
So before closing down the session, a small note of gratitude for the entire team. So I would like to start that this virtual faculty development program was a grand success, and this topic, outcome measures in physiotherapy research, I am sure would have enlightened many of the ignited minds of our profession. So to begin with, I would like to uh, say my gratitude and thanks to our chairman, Dr. Nalaji Palaniswamy, and our trustee ma'am, Dr. Daumanidi Palaniswamy, and the management team who have given us the fantastic and stupendous infrastructure for this FDP platform. And this 10 days would not be a successful and a splendid event without the speakers and the participants. So they are the two eyes of this FDP program. And to begin with, I would like to extremely thank our principal, Dr. Karthik Babu, and our vice principal, Mrs. A.P. Kalpana, and all our HODs and senior faculties, and the speakers who have shared their immense knowledge with the ignited minds of our profession. And my special thanks to our moderators, Mr. Alexander, Associate Professor, and Mr. Bhupati Raja, who had done meticulous planning to organize and take this FTP day by day into a massive event. So this is, I'm sure this is one of the kind in our country where a program exclusively by physiotherapist for the physiotherapist has been done 10 days to make this summer a useful, a day. And to come to the number of registrations, we had a massive response. We got 356 Google Form registrations, and in WhatsApp we had 382 registrants, and the details of registrants are exhaustive. So I'm not going to read, but I have just put up here like in alphabetical order. We have the participants from various colleges under MGR Medical Universities. We have participants from all the deemed to be universities, not only in South India, but also in the North India. And we had lot of independent physiotherapy practitioners who have shown great interest in participating in this event, as well as we have a lot of freelancers who have participated, and we have a diverse population, I mean from ICMR and kind of various different diverse populations also we had participants who had joined in this program online through the Google platform as well as offline through our YouTube channel. Though we had some technical glitches in between, so you all been very comforting, and you encouraged us to take this FDP to the next level. And you can see here the list of entries. So from each colleges, each setup, we had multiple participants registered. So not only national level, we had lot of participants from out of India, international participants registrations also we had. So it was a great honor to us to share our experience and knowledge with the entire physiotherapy fraternity across the world. So thank you, dear participants, for because it is not possible without your uh, intense effort and participation. And so this is just a word cloud to show you your feedback. So your feedback for the week one was amazing, so which gave us the pep to move ahead. And so once again, thank you so much. So we'll be sharing the feedback for the week one, week two, as well as the MCQs for the week two. So kindly work into that, and soon we'll be sharing certificates in the Google Drive. So we'll be looking into your registrations and your participation in the week one and week two, and your certificates will be shared to you. So the WhatsApp link will be active, but it will be kind of not very active till we go for the next season of FDP. So we'll be doing the more of official communication, and anything else you can contact us also. So thank you, dear participants. Thank you so much. So if you have got any feedback, please you can unmute and talk.
Thank you, KMCH team, for inviting me for such a good event. This is my first FDP program from your side. This is such a good organizing team from your side. I literally thank every speaker for putting so much effort for giving us good content for research purpose. So very thank you, communication team. Thank you.
Thank you, Pratik. Thank you so much. So, shall we close the session, or you got? Yeah.
I would like to add one thing. From the organizing team, we would like to so for ma'am, Pramata ma'am, she was the driving force of this team. Unless her commitment, this surely it wouldn't happen this much well. Since from the beginning, from the scratch, registration, preparation, until now, till validatory function, everything she had made everything from her mind it is, and we just assisted her. And thank you, ma'am, for all this support for everything. Thank you.
So, thank you. Yes, somebody want to talk?
Myself, myself, M. Nizaruddin from Devendra College of Physiotherapy.
Yes, sir.
I want to thank Pramata ma'am. Your effort is speechless actually, and Karthik Babu sir for his academic excellence and his effort towards improving knowledge of the people who are in the academic field. Really, this is an eye opener for all the people who are looking for scales and outcome measures, and it's really a qualitative FTP program that can improve the in the fields of physiotherapy. Thank you so much, ma'am.
Thank you, sir. Thank you so much. And last but not least, the IT team of KMCH. So they really did an excellent job. Without them, I don't think this medium where we communicated with you will not be possible. So I would really like to thank, because at the kind of a Twitch we wanted to share it through YouTube because there was enormous amount of registrations. So, and considering the time restraints of the participants, we wanted to give them the comfortable timing to view our our program. So we worked on that, and sooner we will try to sort out whether we'll be able to upload our recorded Google Meet programs also. So I think that's it. So meet you all in the next FDP, which sooner we will come with a better topic with all the feedbacks we have given. Thank you, everybody. Thank you so much.
Thank you.
Thank you, ma'am.